Hello, my pharmacology adventurers. We are reaching the end of our session, and today we're going to talk about irritable bowel syndrome and inflammatory bowel disease. They have a lot of distinguishing characteristics, although they are similar in some ways. And as you might imagine, the pharmacology differs. Let's get started. First, we will look at the differences between IBS and IBD, distinguishing them in the signs and symptoms and the diagnostic criteria. We'll talk about the differences between IBS-D and IBS-C. That's one with a diarrhea component or a constipation component. We'll switch gears into ulcerative colitis and Crohn's disease and the difference between those two. And then, of course, along the way, we'll be talking about the first-line drugs used to treat these conditions. So starting with IBS and IBD, if we distinguish those two, IBS, of course, is Irritable Bowel Syndrome, and underneath that banner we have IBS-C and IBS-D. The IBS-C is one that has a prominent constipation component. IBS-D is primarily associated with a diarrhea component. We also have two distinct diseases under the banner of inflammatory bowel disease. One is Crohn's disease, or CD. The other is ulcerative colitis, or UC. So we will start talking about IBS. It's the most commonly diagnosed chronic GI condition. Most patients complain of abdominal pain, altered bowel habits, and that is in the absence of any other organic cause. It's estimated that between 10 and 15% of the population has some degree of IBS. That is a lot of people. Females tend to be more affected. In fact, it's a 2-to-1 predominance. It seems to result from a neuromuscular dysfunction in the intestine. So in a way, it is a neurological disorder. It results in abnormal CNS processing which leads to gut hypersensitivity. There certainly is a genetic component to it, but for people who have low motility, an inflammation condition, an infection, mechanical irritation, and stress, those are all contributing factors to the severity of IBS. IBS has either a diarrhea-dominant presentation or a constipation-dominant presentation. It really isn't clear why some people experience one presentation over the other. Some of the signs and symptoms you may see in patients are low abdominal pain, bloating, distension. Either the diarrhea component could be over 3 stools a day, or the constipation component may look like less than 3 stools a week. They may feel extreme urgency, passing mucus in the stool, and definitely this can have a psychological impact on the patient. Let's first go over the treatment algorithm for the IBS-C, or constipation dominant presentation. We start with increasing dietary fiber and fluids. That's something that is across the board beneficial for these types of patients. We may add laxatives and consider antispasmodics as over-the-counter or prescription options. And if that is still not effective in treating all of the symptoms, we move to a 5-HT4 agonist. The medication that I'm thinking of is tegaserod. There's also a very important component of helping the patient deal with the psychotherapeutic behavior modifications. You may add antidepressants or help the patient cope with the new reality of their life with IBS. If you choose to add laxatives for a patient experiencing constipation with IBS, you can use psyllium, which is Metamucil, polyethylene glycol, or PEG products. You do want to avoid stimulants like bisacodyl. You may add antispasmodics like dicyclomine or hyoscyamine. These can be in conjunction with laxatives or as single therapy. Tegaserod is the brand name Zelnorm. It's a 5-HT4 partial agonist. It's had some trouble in the past. In fact, it was removed from the market in 2007 due to an inordinate amount of cardiovascular events in patients who were taking it. So it was returned to the market, but now it can only be ordered from the FDA and only in special cases where patients meet certain criteria. It's really deemed for emergency use, and it can only be given to females under the age of 55. That helps mitigate those cardiovascular outcomes. Given the limitations of the therapy that we've mentioned so far, it's a good news that there are some other options. Antidepressants like TCAs and SSRIs have been used for the constipation-dominant IBS. I underline nortriptyline because that's what I see most often in TCAs. You can also recommend use of probiotics. That just helps with general GI health. Another medication called linaclotide or Linzess, it is available to work on the luminal surface of the intestinal epithelium. It helps with GI transit and therefore reduces constipation in these patients. However, there is a boxed warning that relates to use in patients that are under 18 years of age. Another option that works on the apical membrane of the GI tract to increase intestinal fluid is lubiprostone or Amezeta. It helps improve fecal transit and therefore reduces constipation as well. Now let's transition to talking about the diarrhea prominent component of IBS. With these patients, we definitely want to talk about diet counseling, avoiding lactose in a lot of patients, caffeine-free diets. Caffeine can irritate the bowel and cause more diarrhea. For pharmaceutical components, we can consider loperamide to treat the diarrhea, antispasmodics to help with the condition as well. And in conjunction with that, we can consider a medication that is a 5-HT3 antagonist, allocetron. We don't want to ignore the psychotherapeutic behavior modifications that need to happen in these patients as well. Antidepressants may or may not be indicated, but a lot of behavioral changes has to take place when a patient is diagnosed with IBS, and a patient definitely needs help with coping with their new reality. The patient can self-treat with Imodium or loperamide. That is over the counter, usually 4 milligrams with the first stool that is loose, and then following with 2 milligrams with each subsequent loose stool. You don't want to let the patient go over 16 milligrams per day. From a prescription standpoint, we have the same medications we talked about with IBS-C, dicyclamine or hyoscyamin. Both of these are appropriate for IBS-D patients. They offer multiple daily dosing to titrate up to an effective outcome. And there's lots of different dosage forms, oral pills and orally dissolving pills as well. And then finally, the allocetron, the 5-HT3 antagonist, that brand name is Lotranex. It's also only indicated for women, definitely over the age of 18, and there is a box warning related to risk of serious constipation and ischemic colitis with this medication. We do have quite a few other options for treating IBS-D. Again, we can use the TCAs and SSRIs. I underline SSRIs, sertraline and citalopram. These are used most commonly for IBS-D. There's an old drug that is a combination of two medications, chlordiazepoxide, which is a benzodiazepine, and Clindium. The combination is called Librax, brand name. I doubt the brand name is even available on the market anymore, actually. It's so old. But it is an anti-anxiety medication traditionally, but it has some antispasmodic properties as well. We definitely want to encourage patients to use probiotics to help with their general GI health. And an interesting entrant into this category as well is the bile acid sequestrant. You may remember these from our hyperlipidemia lecture. These are used to reduce cholesterol in patients, but they also have the effect of reducing diarrhea in those patients who have IBS-D. Here's a little more information about the antispasmodic agents that I've previously mentioned. Both of them are used for IBS abdominal pain. One is dicyclamine, which is brand named Bentyl. The other is hyoscyamin. It has lots of different brand names depending on the dosage form. Bentyl is usually 20 milligrams once a day up to 4 times a day. With the hyoscyamin, the dose really depends on the dosage form that you select. Patients can take these as soon as they feel symptoms or even anticipation of a trigger that causes abdominal pain. Both of them are not intended for chronic use. They're more for short-term symptomatic relief. Now there are a few new IBS-D therapy options. These are fairly new and as a result very expensive. but they're worth mentioning here because they are brand new on the market and can offer relief for patients who haven't had a lot of success with other therapies. The first one is alexadoline. The brand name is Viberzy. It is probably the only drug that I know of that is dosed based on the presence or absence of a patient's organ. If a patient has a gallbladder, the dose is 100 milligrams BID. And for those patients who do not have a gallbladder, the dose is less, 75 milligrams BID. The other new therapy is actually an old therapy that has been repurposed. It is rifaximin, or brand name Xifaxan. It's an antibiotic that was used for traveler's diarrhea, hepatic encephalopathy, and even C. diff. And when we were using it in those types of patients, we noticed that they did not have as many diarrhea instances. It was tried in IBS patients and seemed to be effective. The dose there is 550 milligrams TID for 14 days, and then you can repeat that. It's very expensive. It's not first-line therapy, but it's definitely an option for patients who have failed other therapies. Let us now switch gears to inflammatory bowel disease. This is IBD for short. IBD is clinically different than IBS in that a lot of the symptoms and pathology that we see in IBD occurs in the areas of the descending colon, the sigmoid colon, and the anus and rectum. Like IBS has two distinct clinical features in the IBS-C and IBS-D, IBD has two clinically distinct features. One is called Crohn's disease, and the other is ulcerative colitis. IBD tends to be diagnosed more often in the Western countries and in the Northern Hemisphere. It occurs in both sexes, but 20 to 30% more women have Crohn's disease, where 60% more men have ulcerative colitis. It's an interesting disease in that it has bimodal distribution by age. The first peak occurs between the second and third decades of life, and then there's a second peak between the sixth and seventh decades of life. We don't know exactly what causes it, but we have some idea about possible triggers. It may be an autoimmune disorder, and that may be triggered by an infection, by environmental factors. It has a genetic component as well. It seems to be a disease that has many, many factors that play into its severity and progression. The two distinct clinical features of IBD are Crohn's disease, and that is characteristic of a transmural inflammation of the GI tract. It occurs across the entire wall of the organ. Different from that is the ulcerative colitis. That is a mucosal inflammatory condition, and it is confined to the rectum and the colon. Here's a quick summary so you can tell the difference between the two. I've highlighted in red the major differences between Crohn's disease and ulcerative colitis. The two major points here is that UC is confined to the rectum and the colon, and CD, upon expection, has a cobblestone appearance. I'll show you the photo of that in a moment. UC tends to be a continuous inflammatory process. You can see here on the images a normal colon compared to a very red and irritated colon on the right. The presentation is usually abdominal pain, bloody diarrhea, an active disease with alternating periods of remission. Again, it's confined to the rectum and the colon. It doesn't involve deeper muscle layers, and it's not commonly seen associated with fistulas. We classify the severity of UC based on the number of stools per day. So it starts with mild at 4 stools or less per day, and then can progress all the way up to the fulminant classification of a sudden onset of severe UC. Now, CD, or Crohn's disease, is a discontinuous inflammatory process. You can see in this image here what I mentioned was the cobblestone-like appearance of the bowel. You typically see patients present with this with diarrhea, abdominal pain, weight loss. The location, however, could be any part of the GI tract, not just the rectum and colon. We classify the severity of Crohn's disease using a number of factors. How well the patient tolerates oral administration, how much they have fever, dehydration, abdominal tenderness, down to weight loss. and then also if there's presence of anemia. IBD can manifest a number of complications if untreated or if improperly treated. Even well-controlled cases can have flare-ups that present in complications. Some of those complications include a toxic megacolon, a stricture formation, fistulas that develop. And then outside of the bowel, you could also see arthritis, ocular involvement even, dermatologic changes. Because it has such an inflammatory component, it can spill over into a systemic inflammatory reaction. Our options for treating IBD first start with non-pharmacologic intervention. That can include surgery, and surgery can be curative for Crohn's disease. But definitely in all these patients, we want to address their nutrition. It is very easy for an IBD patient to be malnourished because their body isn't absorbing nutrition as it would in a normal patient. So nutrition is a major component of any IBD therapy plan. There are pharmacologic options as well, and we dose those based on a stepwise approach based on the severity of the disease. Always we start with IBD treatment with aminosalicylates. We could use antibiotics adjunctively if we think there's an infection component involved, but always at the bottom of that pyramid, the first line treatment is aminosalicylates. As the disease becomes more severe, we add on corticosteroids, and then on top of that, maybe immunosuppressants. And similar to asthma, we can also add on monoclonal antibodies. For patients who are just not getting relief with any of the other things we've tried, they are expensive and they are never first line, but monoclonal antibodies are a newer approved treatment for this condition. First and foremost, always first line therapy is aminosalicylates. We may call them ASAs. They are metabolized to sulfapyridine and mesalamine by the bacteria in the colon. So, as you might imagine, a patient that does not have normal or functioning gut bacteria will have a problem with aminosalicylates. Once the metabolism happens, this mesalamine component inhibits the COX and leukotriene synthesis to reduce inflammation. Some of the adverse effects you might see in a patient that's taking aminosalicylates is fever, rash, nausea, headache, and diarrhea. Dosing is highly dependent on the formulation that you select and the severity of symptoms, so it's very patient specific. This is one medication that has multiple dosage forms, doses, brand names available. There are products that are for rectal administration, so rectal enemas like Roeza, and rectal suppositories, Canasa. Those are both the active ingredient, just the mesalamine. Then there's the sulfasalazine, which reduces irritation and swelling in the intestine. Other formulations of mesalamine are dosage form related, so multi-matrix delayed release, encapsulated microgranules, and in the case of a product like Asacol, it is formulated to release only in the terminal ileus, so targeting an area of the inflammation. Even more forms of aminosalicylates come in oral forms like olazoline or dipentum. It is two 5-ASA molecules linked together, and when they are metabolized by the intestinal bacteria, they are broken apart. This is a product that's really expensive and really not first-line therapy compared to the other medications we've already talked about. There's also balsalazide or colazole. It's a prodrug that is metabolized into mesalamine when it is taken internally. It doesn't have much systemic absorption. It stays in the gut and acts locally. It has a quicker response rate and a higher rate of complete remission than the other alternatives, but it is also expensive. Here's a summary of all the different mesalamine and sulfasalazine ASA type of medications that are on the market and their doses. I just give this to you because I want to demonstrate how many brand names, how many dosage forms, and how many available doses there are. Do not memorize these for the course. You will always look these up when you're actually prescribing for a patient. But I do want to say there's not a one-to-one conversion between products. So you can't easily substitute between brand names or even between dosage forms. So we've covered the first line of the aminosalicylates for IBD. As the disease progresses, we may need to use antibiotics, and let's talk about the case for those situations. We want to use antibiotics for IBD when we see there is evidence of fistulizing disease. It's not routinely recommended, but definitely should be used in the case of a fistula. The medications we most often use in this case are metronidazole or Flagyl. The other one is ciprofloxacin. It's used as an alternative to metronidazole in a patient who cannot take metronidazole. As you remember from our antibiotics lecture, there are many drawbacks to using a fluoroquinolone like ciprofloxacin. So in most cases, you will definitely want to use metronidazole. The only case where you wouldn't is if there's a documented metronidazole allergy. When we need to add on corticosteroids for IBD, we can do that using the tried and true oral prednisone or prednisolone. There are products that specifically target the ileum and ascending colon. Two products, they are to the same drug but different dosage forms. One is Intocort. It's specifically used when the pH of the ileum and colon is above 5.5. You can use it up to 3 months. And then in another case where the ileum and ascending colon, the pH is above 7, so that would be a product called Ulcerative, and you can use that up to 8 weeks. There's also a hydrocortisone enema for localized disease, and that's another way that we target the inflammation happening at the lower end of the bowel. Moving up our pyramid of more severe disease, we can add on immunosuppressants. Azathioprine or AZA, mercaptopurine, 6-MP, those are both very old immunosuppressants that inhibit nucleotide biosynthesis. They have a lot of adverse effects, a lot of drug interactions, so they should be used carefully. Generally at this point, a GI specialist should be handling the patient, or at least initiating this type of therapy. Cyclosporine and methotrexate are also two options for immunosuppression in IBD. And then finally, at the top of that pyramid of severe disease, we have the monoclonal antibodies. I've listed several here: Humira, Remicade, and Cimzia. They are all not PO. They are in either subcutaneous injection or an IV infusion. These are not things that you're going to encounter or even initiate in family practice. But you should know about them in case the patient has them on their profile list when they come to you as a patient. For both of these, you must rule out TB before starting a therapy of monoclonal antibodies. Natalizumab or Tysabri is another monoclonal antibody, also an IV infusion. There is a boxed warning for this medication, specifically related to an increased risk of progressive multifocal leukoencephalopathy. Vedolizumab or Intivo is an IV infusion monoclonal antibody. It works in a different way than the other ones we've mentioned. Again, not something you'll probably encounter in family practice. IBS and IBD are very common conditions that you will encounter in family practice. Some of the more severe diseases should be referred, but you're perfectly capable of managing most patients with these conditions.